Four, three, two, one. Good afternoon. This is Dr. John Bennett, broadcasting from Miami. Today, we have another in the series of the neurosurgical channel of Larkin Hospital TV. We once again have Dr. Richard Mendel, the spinal neurosurgeon, Richard Mendel, MD, the spinal neurosurgeon from Tampa and Clearwater. He's going to be talking about normal pressures, hydrocephalus today. And we have a couple of distinguished panelists. First, we'll start with Shajish. How you doing, Shajish?
Hello, hi everybody. My name is Shajish Kyriakos. I'm a head and neck maxillofacial surgeon, and I teach in Larkin Health Science Institute. I teach neuroanatomy, neuroscience, and neurophysiology, and I'm really thankful for being on the panel today. And thank you very much, John.
You're welcome, Shajish. And Shajish may be doing some head and neck surgery hangouts soon. Welcome, Mohammed.
Hello, everyone. My name is Mohammed Saleh, and I'm joining today from Windsor, Ontario. Glad to be with you today.
Welcome, Mohammed. Okay, Richard, it's all yours.
Well, today I thought we would just do, because it's, a holiday weekend, we'll just do a short presentation on what a lot of people refer to as normal pressure hydrocephalus. And that got first described by Victor Adams, the neurologist, in the 60s. I think it was like 65. And, lots of medical students know normal pressure hydrocephalus. Like, they'll learn it in their first clinical years as wet, wobbly, and weak, or they'll use something like that where it's a triad of urinary incontinence, a degree of confusion, and a gait that's sometimes called a magnetic gait, where the patient actually walks as though they're stuck to the floor. And to this day, there's really not a real consensus or algorithm or protocol for how to treat normal pressure hydrocephalus. But there is kind of a consensus about in different areas, and I really think it's because when we talk about normal pressure hydrocephalus, it's not really clearly defined, and I think that we're not dealing with one disease entity. We probably don't know as much as we need to, and I think over the next many years we're going to get better at predicting things. The problem with normal pressure hydrocephalus is that you're dealing with one of the dementias, but it's a small portion of dementias. In people that are 70 to 79 years old, I think only a very small percentage, like 0.2% of all dementias are from, quote, normal pressure hydrocephalus. But as soon as you hit 80 years of age, it goes up to like 5.5%. And this data really just came from a recent review by Luke Jasmine, and he mentioned several things that I thought were worth repeating, because normal pressure hydrocephalus probably is probably a lot of it has to do with a change in the compliance of the brain itself, because when people talk about normal pressure hydrocephalus, they talk about very enlarged ventricles, but the sulci really aren't effaced anywhere near as much as you'd think they would be. And so perhaps the brain is just getting less compliant, or an issue such as that, like maybe something's going on, like there's axonal degeneration. We don't really know. The things that you do know, though, are that normal pressure hydrocephalus, the subtle higher function changes often go on for many years before it becomes somewhat prominent, and the gait and the urinary incontinence appear. So this is something like that can go on for a long time and not be clinically evident until the urinary problems start. And the urinary problems start just as you'd imagine. It's not sudden incontinence. It's a dribbling. The dribbling gets worse. Then it's urinary urgency. Then fluid wetting themselves. And one of the things that Dr. Jasmine mentioned is that fecal incontinence is really, really rare. Really rare. So if you've got a patient with fecal incontinence, it's probably not NPH. The other thing is, the more the neurologic changes represent a cortical problem like an agnosia, an aphasia, a paresis, the less likely it's going to be normal pressure hydrocephalus. NPH is kind of a subcortical dementia. And so my thinking on this is that right now there's two kinds of normal pressure hydrocephalus. One is the primary, or what we always call idiopathic NPH, and then secondary NPH. We know the cause of idiopathic NPH, but secondary NPH can be secondary to a problem such as a subarachnoid hemorrhage, meningitis, and infectious etiology. Several different things can trigger the quote secondary NPH. So is that a good characterization of NPH? I don't really think so. I think it's just kind of going to turn out to be several other diseases that creep into the dementia diagnosis. So NPH gets treated differently in a lot of places. I think in the US, the consensus is that to work somebody up, you want to sample the spinal fluid first. Once you've ruled out, all the other standard causes of dementias, but when you suspect it's NPH, you really want to do a lumbar puncture, and you want to do something that we don't put as much value in as older neurosurgeons did, and that is you really do want to measure the pressures, the opening pressures, and that's an important part of NPH, because once you see an opening pressure higher than 20, that's not normal pressure anymore. That's a more standard hydrocephalus, and so you have to remember that you want to tap the patient in a position where you can get a reliable measurement. Most of the people used to do an LP tap with patients lying on their side, and you would measure 0 as 0. A lot of times, in these patients have had lots of surgery, and I'll do them sitting up, and I just use a longer tubing to equilibrate it, so I measure 0 as at the external auditory meatus. I consider that 0. So, but you want to know that the pressure that you're getting is falling within quote normal pressure, which is 20 or less. And Dr. Jasmine, gives a lot of good references in a recent review article. But he really felt that the people that were above 14 centimeters of water or millimeters of mercury, at that level they're almost the same, do much better with shunting. And there's a recent textbook that came out about the complications of shunting. Shunting is often a really good device, a ventricular or perineal shunt with an anti-gravity device in it, like an anti-siphon device, is really great. But it's not without complications. And the complication rate that Dr. Jasmine cited and laughed about it was that it's 29 to about 96%. And a lot of it is because you may be putting a shunt in somebody who's already got a more advanced dementia. And, you know, the truth of the matter is, you know, once somebody reaches a significant dementia, the lifespan is about 7 years after that, pretty much at most. And so, you know, if you're not catching this early, your results aren't going to seem very good. And I think over time, we're going to have to get a better handle on what the real changes are in the brain's compliance, because you know, it's hard to imagine why it's at a low pressure these issues are developing unless there's something going on physiologically. I mean, anatomically, we don't really. It's very hard to say. There's different indices that are used, like the Evans indices and the measurements about the size of the fourth ventricle, and there's a lot of discussion that a lot of people believe the fourth ventricle has to be dilated. It doesn't have to be dilated in normal pressure hydrocephalus. So I think that when you're working up NPH, the first thing you want to do is get a good measure of an LP, and you want to do a high enough volume tap, 10, 15, maybe even 20 cc's the first time to see if there's any improvement. A higher volume tap's okay. You just don't. The problem with over draining somebody or with putting a lumboperitoneal shunt in is that if you over drain them, they're at risk for a subdural hematoma or larger hygromas forming on the surface of the brain, and then you've converted, you know, a hydrocephalus, large ventricles to smaller ventricles, but because they're being pushed by large fluid collections from the periphery. So NPH still isn't a really well it's still a little bit of an amorphous thing. It takes a lot of judgment to determine who's best suited for a lumboperitoneal, a ventriculoperitoneal shunt. In other countries, like in Japan especially, the idea of neurosurgery doesn't sit well with a lot of people, and so a lumboperitoneal shunt often gets inserted. Lumboperitoneal shunts I don't really like very much because I don't know when they're working. It's hard to tell when they're working if there's a clinical change in the patient. And the other problem with any kind of shunting, lumboperitoneal, ventriculoperitoneal, in an obese patient, a lot of times if you do a ventriculoperitoneal shunt, an obese patient, which is not rare in America, they can have an intra-abdominal pressure so high that the shunt doesn't function well. And if they're obese, you don't know that the lumboperitoneal shunt's working well either. And other pharmacologic treatments, which have been around a long time, like acetylzolamide, it doesn't really yield a very satisfactory outcome in the past. And I really, to be honest with you, I don't shunt people that much anymore because my practice is more spine-based. And shunting seems like a simple procedure, but it is not. It's difficult to place a shunt without revisions and quite a bit of frustration. So I'm hoping that in the next few years with better technologies, we'll get an idea that normal pressure hydrocephalus isn't one entity. It's probably a lot of other things going on that we really don't have such a great handle on yet. That's really about it.
Richard, thank you very much for excellent presentation. Now, how do patients get to you? Are they already diagnosed with it, or they say,
Well,
Dr. Mendel, we have a patient with dementia, we can't figure out why?
yeah, well, a lot of times what happens is um, the patient will have gotten an MRI, and maybe a neuroradiologist says possible dementia. I'm sorry, possible normal pressure hydrocephalus, and and a lot of times, if the MRI is gotten for a good reason, that's great. But if the MRI is not gotten for a great reason, you have a patient that seems to be doing well with ventricles that are questionable. Oftentimes, the best thing to do there is observe them. But yeah, a lot of times patients are referred to you because of an incidental finding on an MRI or a CAT scan. The best referral for NPH is going to be when a neurologist has already worked them up and says, look, what do you think? And it's very good, especially if you're someone like me who does mostly spine now in private practice. It's good to work with a neurologist so that you're convinced that there really is a change in the patient when you do the lumbar puncture. Because, another option, and I did this a lot, was I would do the first puncture, see how the patient did, and then I might admit them for a few days and just do a lumbar drainage for several days, like do a lumbar puncture and place a drain and drain them slowly for several days to see if they got better. Because unfortunately, a lot of times, the family really wants the patient to get better, so that you place the shunt, and in the hopes that they are getting better. And they're not, the patient's family's not lying to you. They so much want the patient to be better that they can take very subtle findings and think, oh, they're much better. And you really want to be able to rely on someone like a neurologist who could say, I really think they're better, or I'm not sure they're better, and they can do like something more than a mini mental status exam to really determine the patient is better. And you can imagine in the days of managed care and everything else, nobody wants you to admit a patient for 3 or 4 days of lumbar spinal drainage to discern whether or not they're demented. It's very hard to get people worked up well.
Mm-hmm. Sajish and Mohammed, do you have questions?
Well, thank you, Dr. Mendel, for the great presentation. I have one question regarding the shunts they use. I know, like I read, they use the lumbar shunts, the ventricular, and there's one that the right atrium shunt. Can we know like a little bit more about this type of shunt? Like, how often is it used?
Yeah, that's a great question, and it's really a topic unto itself. But it's a great question. In the late 50s, I think there was an engineer named Halter, Holter, and he had a child born with hydrocephalus, and the consulting neurosurgeon couldn't really treat the kid, and Halter developed a valve that became named the Spitz-Halter valve after the neurosurgeon Spitz. Of course, his name went first, but Halter thought of everything. And Halter and Spitz became very famous for placing a valve. And that first valve was from the ventricle to the right atrium. And for years, that was the standard. But what's happened in the U.S. is that we tend to drain babies more to their peritoneal space. now rather than going into the atrium. Going into the atrium got a renaissance though a while ago, and I'll tell you about that in a minute. But the lumboperitoneal shunt doesn't go into the brain. It goes into the lumbar spine, and then you tunnel it around the person's flank into their belly, and you put, it goes into the peritoneum by tunneling it around the retroperitoneum. The problem with anything going into the retroperitoneum is in a patient that has disease or has had bad peritoneal infections before, or a lot of surgery or scarring, the peritoneum won't drain as well as it should. Also, there were some issues with nephritis, I think. But in babies, the peritoneal space was a good place to put the tip of the catheter. Later on, several years, this is probably 20 years ago, this really bright Egyptian neurosurgeon had a new technique because he had such limited resources in Egypt, and he was treating all these Alex. So what he was doing was he was putting the routine ventricular shunt in, but he didn't have valves. The valves is the most expensive part of the apparatus. So he would just take this tube, place it into the brain, and then he would place it into the vena cava, vena cava against the flow. And because it was against the flow, there was enough turbulence that it kept the tubing open, and it worked. It worked well, and it was much less expensive. And I think that did well. In the U.S., of course, we still use valves and anti-siphoning device. So when the child goes from a recumbent to a erect posture, there's not a change in the amount that drains. But the history of shunts is really quite complicated. A lot of people have tried a lot of different things.
There are no studies, Richard, that say shunting is the best thing to do?
I think overall the consensus these days is that for NPH you want to do I think a ventricular peritoneal shunt in this country is still the standard. And that's what Dr. Jasmine finds in the neurosurgery practical reviews last month, the August 15th edition. That's what he espoused. And, people will talk about shunts as though they're low risk, they're a common everyday thing. Neurosurgeons who are good can put a shunt in minutes. But that doesn't mean it's easy, and it doesn't mean it's without risk. There are risks. There's infection risks, and I think you're most of the time better off going to someone. The pediatric neurosurgeons are great at it. Lots of adult neurosurgeons put them in, but you want somebody that does a high volume of them, because there's a lot of things that can go wrong, and those patients have to be followed closely to make sure. I mean, even if they're drained at a little bit too high a pressure, you may see hygromas, fluid collections on the outside of on the cortex develop, but it may take months. So you want to be very scrupulous with the shunting and the shunting follow-up. It's not just an easy, people that may not be as familiar with shunting may talk about it as though it's just like a passe easy thing. It is not. It's not at all. So,
Shajish, you have a question?
Yeah, Richard. Yeah, I just wanted to know whether the VP shunt. Would you consider the most commonly used shunt in this day and age?
In the U.S. and in London, in England, it is the VP shunt. when people talk about a shunt, they just almost leave off VP because shunt, that's what you do first.
Oh, okay.
But you know, if you've got a patient that's had renal problems and has a scarred-in peritoneum, you still may want to go to the atrium. There are other places you may want to go. Lots of good, lots of surgeons, neurosurgeons who got very good at endoscopy would do a balloon dilatation for non-communicating hydrocephalus. That's another technique. I don't do that. I mean, it's not a exotic procedure, but it's not something that I think I'm still good at doing because I do it so infrequently. But lots of people do it.
Yeah, well, we used to come across a lot of these hydrocephalus in the Middle East.
Oh, sure.
While I was working there, and I had a good friend of mine, a neurosurgeon, who used to swear by the VP shunts. He thought the chance of the complications, which is mainly blockage, was an infection, yes. These two was quite low, but I'm talking about 20 years back. So just want to know what's the current status.
Well, somebody with a high volume like your friend is probably very good and the complication rate is very low. But I'm sure it still keeps him up at night worrying because he may have 1,000 kids with shunts, and you're always worried about, even if it's, even if your infection rate's small, you're always worried about shunt infections and shunt blockage. And, the one thing I learned, I mean, always listen to them. If a mother tells you the shunt's blocked, it's blocked. If they tell you there's a shunt obstruction, that shunt's obstructed whether you think it is or not. So, yeah, in the Middle East, where, you just don't, you may not have, you can have tremendous resources in one city, but out in the rural area have no resources. The guys that are putting those in, I'm sure, are very good and have a very low complication rate.
Oh, I agree with you. Mother is the best source, especially all over the world, but particularly in the Middle East, because they are so, I mean, I don't know the language, so, I just look at the mother, and if I see her upset, I know something is wrong.
Oh, yeah. And if you try to tell the mother that you've done a test and you know that it's not blocked, you'll be sorry, because within 12 to 72 hours, you'll be apologizing to her, telling her, I should have listened, you were right. It may not be blocked, it may just be infected instead, which is even worse. But the mother knows when something's going on.
Yeah, absolutely. Agree. Thank you very much, Richard.
Yeah.
Richard, one more question from a Twitterer. Is there a specific age group that tends to see normal pressure hydrocephalus cases more than others?
Yeah, like I said, normal pressure hydrocephalus, the incidence isn't really very, very high, and if in the 70 to 79-year-old age range, that's like 0.2%. I think Luke Jasmine said, 0.2% of all dementias. But the minute they turn 80, it becomes 5% of all dementias. Dementia is really common. So 5% of dementias, NPH explodes at about the beginning of that 9th decade. So, I think really that we have all kinds of organs, and some organs are better in some ways than other organs. I don't know if the brain's meant to live 9 or 10 decades. I mean, I know people do well, but I think, when you get up there into that 9th decade and you see the change that goes from 0.2% to 5% of all dementias, I'm not sure we're tracking the entity right. I'm not sure we know maybe as much as we need to yet.
Well, that'll be interesting. Well, okay, Richard, we'll keep it short and sweet since it is a holiday. weekend. The college kids are quiet today.
Yeah. Well, yeah. What do you have anything you want to talk about next time? I
Uh,
mean, shunts aren't
that's okay.
shunts aren't fascinating, but they make my blood run cold actually. But you have to know how to take care of a shunt. I mean, that's critical.
Yeah. Well, that brings up another question. Are nurses have to be specially trained, or most nurses can figure it out?
You know what? I'm a board certified neurosurgeon, and I can't. I still
Oh,
can't
really?
figure it out half the time.
Uh-huh.
I mean, I had a junior resident 1 year behind me, and he was much better at figuring out shunts than I was. I would sit there. I mean, you always have to rule out blockage and infection. It's difficult.
Very good.
But
Okay,
yeah, I don't think you could depend. I mean, a nurse may have a good sense if she's a full-time pediatric neuro nurse. She'll have a pretty good sense of what's going on. But I think she, like a lot of people, we don't really know as much as we should. So she has a good instinct, but I think you have to prove it to yourself that shunt is or is not working. And of course, you can do procedures like inject the shunt under X-ray, under fluor with dye and see that it's working. But remember, every time you touch a shunt, it doesn't need to be touched, then the infection rate goes up.
right, right. So
So
mostly it's a clinical intuition that it is.
yeah, because you have to try to figure out if the shunt is blocked between the catheter to the valve, whereas the valve isn't working, or if it's blocked distally going into the belly, and so there are a few different ways to determine that. And Sajish, you'd probably be interested, where you place the catheter, because most people, I think these days, place them in the right frontal area about here, but a lot of guys still will place them posteriorly through the occiput, and there's subtleties about each one of them. So I think that's outside this.
Very good. Very good, Richard. I thank you for coming out today, and then we'll think about what we're going to do next week. And
I'll think. Well, if somebody has something they want to talk about, we can, or I'll try to find something.
very good. Okay, Richard. Thank you very much. Have a good. Now that you know it's a holiday, have a good holiday weekend.
All right, Sajish and Muhammad, thanks.
Okay, thank you.
Bye-bye.